data of our study, Antinuclear Antibodies in Women with Recurrent Early Pregnancy Loss, the prevalence and impact on subsequent pregnancy outcome. Recurrent early pregnancy loss is defined as the occurrence of 2 or more spontaneous pregnancy losses before the 10th week of gestation by Eshrey. Different risk factors have been identified, such as parental chromosomal abnormalities, anatomical uterine anomalies, lifestyle factors, endocrine disorders, thrombophilia, antiphospholipid syndrome, and immune disease. Nevertheless, in more than 50% of cases, no etiology or risk factor is found. And that's why research in this area is, of course, of great importance to understand this better and to help these patients with their physical and psychological distress. Autoimmunity and antinuclear antibodies in specific gained some interest lately to be potentially associated with recurrent early pregnancy loss. The antinuclear antibodies, or I will call them also ANA in this presentation, are a group of autoantibodies against nuclear antigens. There are some studies investigating the association with recurrent early pregnancy loss, and there we see some contradiction and some contradictory results. So we have some studies that found a higher prevalence in ANAs in patients with recurrent early pregnancy loss, but we have some studies that cannot confirm this. We have a meta-analysis of Calvacante et al. And Chen et al. That stated that there was a higher pregnancy loss in ANA-positive patients. However, it's difficult to draw firm conclusions because the sample sizes of the studies included are quite small. The definition of recurrent early pregnancy loss is different. Also, the definition of ANA positivity and their cutoff titer is different, and the testing of ANAs is different. So that's why we made our research question: what is the prevalence of antinuclear antibodies in women with recurrent early pregnancy loss, and do they affect a subsequent pregnancy outcome? We designed a 5-year single-center retrospective study where we included women with recurrent early pregnancy loss, as mentioned before, using the Eshrey guideline, the Eshrey definition. And here the exclusion criteria are presented. To detect the ANA, we used the indirect immunofluorescence using the HEP2 cells, which is known to be the golden standard. We used a screening titer of 1 out of 80, and the staining pattern is based on the ICAP nomenclature. The first part of our study, where we look into the ANA prevalence, we could include 960 women with recurrent early pregnancy loss. When we used then a cutoff titer of 1 out of 80, we found 125 ANA-positive patients. This gives us a prevalence of 13%. In literature, we found a big cross-sectional US study where they investigated the prevalence of ANA in the normal healthy population, and they found a 15.9% prevalence. Also, in a multicentric international study, they found a prevalence of 13.3% in a normal healthy population, which is similar to our prevalence. Then when we use a cutoff titer of 1 out of 160, what is sometimes used in studies, we found 77 patients who are positive, and this gives us a prevalence of 8%. Here are the baseline characteristics of the ANA-negative and the ANA-positive group. There are no significant differences in the baseline characteristics, except for the thyroid autoimmunity. We see that the ANA-positive patients have a higher thyroid autoimmunity, which is also already known in literature and could potentially indicate a more complex status of autoimmunity. For the second part of the study, where we investigate the subsequent pregnancy outcomes, we have our 960 women, where we excluded 185 women who were lost to follow-up. We excluded also 18 women who were more than 40 years old at the time of their next pregnancy, and 8 women turned to the oocyte donation. So we had 749 women that we could monitor for their pregnancy, for the subsequent pregnancy outcome. 595 conceived again, and this is a mix of spontaneous conception and conception after ART. Of these 595 pregnancies, we have here the baseline characteristics, and again, there's no statistical significant difference except for the thyroid autoimmunity. Here we have the crude unadjusted outcomes of these pregnancies, where we see that there is no difference between the ANA-negative and ANA-positive group in terms of early pregnancy loss rates, the biochemical pregnancy loss rate, clinical miscarriage rate, and also the live birth rate. Of course, we wanted to have a look deeper into the data, and we had a look at the outcomes according to the ANA titer. And we have the negative titer, the titer of 1 out of 80, the titer of 1 out of 160, and the titer of 1 out of 320 or more. And we see that there is no significant difference between all groups in terms of early pregnancy loss rates and live birth rates. So we could conclude that there is an absence of a clear titer-dependent effect. Secondly, we wanted to have a look at the outcomes according to the ANA pattern. We have the ANA pattern who is homogeneous, who is nucleolar, speckled, dense fine speckled, or others, or a mix of more patterns. Here we see also no significant difference in terms of early pregnancy loss rates and live birth rates. So there's no ANA pattern dependent effect. A logistic regression was done to investigate the impact of ANA positivity on the likelihood of having another early pregnancy loss, and we see that the ANA positivity is not significantly associated with another early pregnancy loss. However, we found age was an independent predictor of another early pregnancy loss, which is quite logic because of an increase of embryonic aneuploidy. Secondly, we also find the Arab ethnicity to be an independent predictor in our data. This could be explained, first of all, because we have a patient population referred to us, to our center from the Emirates, with already quite complex files of recurrent early pregnancy loss. And secondly, we see a higher prevalence of consanguinity in this ethnicity. To our knowledge, this is the largest sample size to date in this area. We excluded patients who were 40 years or older, which is a strength. The limitations are, of course, the retrospective design and that we have no control group without recurrent early pregnancy loss. And when we had a look at the specific fluorescence patterns, we were talking about small sample sizes. To conclude, we found no higher prevalence of ANA positivity in women with recurrent early pregnancy loss compared to the general population. Secondly, we found no significant impact of ANAs in the subsequent pregnancy outcome, neither titer nor pattern. So this is quite interesting to help the counseling of these patients, as well as to refrain from non-evidence-based immunological treatments. Of course, the question is, should we screen for autoimmunity in asymptomatic women with recurrent early pregnancy loss? Well, that question is difficult, and the answer is also quite difficult, because ANA is a good diagnostic tool, but we know that autoimmunity is quite complex and extends beyond ANA only. So diagnostic tools to have a good diagnosis at first is of great importance, and of course more studies in this area is needed. I would like to thank my colleagues to have the lovely collaboration and the support, and I would like to thank you for your attention.